Well, joining us now in studio is the president of Health Professionals Council of South Africa, Kgosi Letlape. Very good evening to you, sir. Thank you so much for joining us this evening. Just talk to us about your sentiments on the cancellation of those co-payments, especially with medical aids.
Good evening to you and the viewers. I think the cancellation will come as a relief to both patients and providers. Because when there are co-payments, it usually means that there'll be outstanding bills for patients to the providers of services. It also gives uncertainty to members of medical schemes as to what they are really entitled to. So by getting rid of the co-payments, the medical aids will be forced to negotiate better rates with providers that will be willing to take what is negotiated as full payment for the services.
And how will the government actually pay for this? I mean, the bill actually doesn't really mention exactly how it's going to get paid for. Will it be from the taxpayers' money? Is there any specific?
No, remember, the issue of co-payments are reforms to the medical schemes. And that is a separate discussion from NHI.
Yes.
So medical schemes will still be funded by members that can afford to be on medical schemes that will be subsidized by their employer. If you are a government employee, you'll be subsidized by government. So the pool remains the same, but the rules change. And by changing those rules and getting rid of things like co-payments, you are giving stability to patients. So that, we've had patients where from co-payments, they've become bankrupted by co-payments.
Yes.
They've had to sell their homes. So that would now be prevented by this new rule. But what it's going to necessitate is that urgently we need to have a framework, a pricing framework. So we have to have statutory tariffs that are determined as soon as possible. And they will be negotiated with the different providers of services. For example, I'm a medical doctor, and I hope that the interest groups in the medical fraternity, being the associations and the societies, will be brought together to negotiate with the medical aids that are the payers about what would be the rates that are agreed for the services that are rendered.
So once this framework is put together, what happens to, if I have medical aid, for example, of course I won't have to pay do any co-payments anymore. Should I still stay on the medical aid? Can I just, go under the NHI?
People must not be confused. The NHI, we're now getting into phase 2, and it will only be implemented phase 3. So we still have about 8 years to go. Remember, what was launched was a 14-year program. The first 5 years have elapsed, and we now got 9 more years. So there'll be a second phase, and there'll be a final phase. And from the minister's pronouncements, the anticipation is that full-fledged NHI would be unrolled around 2026. So there's still some way to go. So for now, people that are on medical aid would still carry on being on medical aid. But the reforms that are occurring give them better security for the benefits under medical aids. One of the other issues is that if you ask anybody on medical aid currently, they don't know what they covered for. It becomes a surprise when you need it, and there are lots of gaps that you need to fill in terms of payment. So those are what we call co-payments. By getting rid of that, you are giving the people security. But people mustn't think if you leave medical aid now, you use the public healthcare system. But there isn't an NHI fund that has been established at this point in time. So it would be like last year, you giving up your medical aid.
Yes.
So that will be the same situation for the next five years.
So come 2026, when we get to the third and final phase, what sort of services will the NHI offer? Will it be everything that medical aid is and more? How would it compare?
I think South Africans are quite confused, and they like misdirecting themselves about what will the benefit structure look like. If you look at the promises of our Constitution, Section 27, it promises citizens and residents quality health care within available resources. So what you will have is what the collective resource can pay for. So it's all included until specified otherwise. That's why people sit on medical aids thinking that everything is covered. But it's only when the rubber hits the road, when you use the system, that they tell you, oh, for this we pay 80%, oh, for this we don't pay, for this. So it's a false sense of inquiry when people say what is going to be covered. Everything is going to be covered within what we can afford. And what will be specified will be what is not affordable or what will not be covered. For example, in most systems, cosmetic surgery is not covered.
Yes.
So there will be things like that. But basic care will be covered within available resources. And that is why when you look at the way it is structured, there's the purchasing, the central purchasing. It means people will have the bargaining power to negotiate on behalf of 55 million clients. And they'll be able to get the best prices possible for commodities. They'll be able to negotiate better prices for services of healthcare professionals, including doctors, because they are covering the number 55 million. Right now, medical aids only cover 16% of the population, 7 or 8 million people. And even those don't know how well covered they are until they have a need. I mean, you'll be on medical aid for 30 years without claiming a dime. And one day you get into your 50s, your 60s, you claim you got shortfalls. And then soon you go on pension, and unless you continue paying premiums, you got no cover. So all those premiums that you've paid are being taken away by brokers, are being taken away by administrators. Now, when we put our money into a pool, when I'm still young, I'm contributing. When I get old, the system takes care of me. And my children come in and take care of everybody. If I'm unemployed, I'm covered. If I get employed, I pay my share. If I'm poor, I'm covered. If I'm a child, I'm covered. If I'm old, I'm covered. If I'm active economically, I will be contributing more because I have the ability to pay. But we're paying for the safety net for all of us.
And you just mentioned something, the brokers, medical aid brokers, doing away with brokers, will that also help to reduce premiums for people?
Yes, why do you need brokers? And brokers have not added value. The size of the population of people on medical aid has never really grown in the last 15, 20 years. And they are just churning, moving you from metropolitan to discovery so that they can earn the commission. So they are not needed in the system. So you get rid of them, you got a 2.2 billion rand saving. They don't add value. Now, if the Constitution says all of us should be covered, why do you need brokers when all of us need to get the healthcare that we need?
Some people will actually be going out of work.
But there's also some other things that have not been said. Administration costs are quite huge. So once you're working on the basis of all covered, and you are not trying to say this is not covered, this is not covered, that becomes admin intensive. When you have 10 different schemes, options in your medical aid, it's admin intensive. When we do away with those things that everybody is covered and we cross-subsidize each other, it's simpler administration. So less money goes to administration, more money will be available for services.
For the actual services. Now also, what will be done about, some people actually have some concerns about the quality of managers in the different health departments. What will be done about those people that are in leadership positions in the Department of Health, whose capabilities are somewhat questionable?
You see, what people fail to realize is that when we say we're not going to see managers in the health department, you're going to see healthcare professionals on the ground. So your concern should be about 70% of specialists working in the private sector for 16% of the population. So what we should be concerned about, how are we getting those professionals back into the public healthcare system? The fact of who sits in admin in the department is not important. But another area of expertise that comes through the bill for NHI is ministerial committees. So we'll have South Africans with expertise serving in the appropriate committees to make the national health insurance work. So all this talent that's crowded for 16% of the population will now have an opportunity to express in talents to service 100% of the population.
Well, thank you so much, Mr. Letlape. We do look forward to 2026. May it come sooner. That was Mr. Kgosi Letlape from the Health Professionals Council of South Africa. It is time now for a shorter weather break. We're back with more news, so don't touch that dial.